So this is going to be the final lecture on seizures, and we're just going to go through a handful of cases. I feel that it's better for me to just go over a few cases rather than a ton of cases, the whole idea of quality over quantity. So we'll start with this first case, which is a 2-year-old male neutered Labrador. And the owner has seen the following episodes that occur around 10 p.m. at night. The first episode happened about a week ago, and then the same episode happened last night. And this dog has been with these owners for about 2 years, so since he was 3 months of age. And he's pretty well taken care of. He's up to date on vaccines and preventatives and has a nice comfy home, as you'll see. So these are the episodes that they're describing. So things that you should be thinking about with these episodes is what part of the body is involved. What does this patient's mentation look like? What is his behavior doing? When you watch these episodes, you can tell that he seems bothered by what's going on. So I'm sure you can tell at this point that it's mainly the head that's involved. But you should be thinking with something like idiopathic head tremors, would you expect them to be irritated by what's going on? So something that you're going to be asking yourself right now was this an epileptic seizure? And as you're going through that, you're going to be thinking, what was the phenotype? As I was discussing through the video, were there pre-ictal signs or post-ictal signs, which in this case there were not, at least on these videos. Is there an association with anything? So was this patient exercising before the episodes that occurred? Was this patient eating before the episodes? Now obviously this is a male, but for some patients, seizures can actually be triggered by estrus. Another thing you should be asking was, how long are these episodes lasting? And then another thing you could be asking the owners, is there any sort of known toxin exposure? Whether did they spray like ant poison around the house recently? Have they given the dog any sort of flea preventatives? Could the flea preventatives be new? Could the heartworm medication be new? Because some of those have been associated with epileptic seizures. So the answers to these questions, as seen in the video, are provided by the owner. It mainly involves the head, but again, he does appear to be disturbed by the episode. But one thing that the owner does let you know and why they came in is because this morning they actually woke up to the patient thrashing in his kennel, and they tried calling him to get him out. And the episode itself, from what they could tell, lasted about 20 seconds, although they were asleep. So they're not sure how long it potentially could have been going on before they woke up. And then as far as was there any pre or post-ictal signs, at least on the previous episodes there were none, but this morning after the thrashing had stopped and they got him out of his kennel, he did seem pretty dazed for about 20 minutes or so afterwards. He just wasn't quite himself. And then was there any sort of association? As far as they know, there wasn't. The only thing that happened was the previous events occurred late at night, again around 10 p.m., except for this one, which occurred in the morning when he was in his kennel. So there was no known toxin exposure with any of these events, and he hasn't received any flea or heartworm preventative within the last few weeks. And then as far as how long did it last, as you saw in the videos, they're lasting about maybe 20 seconds or so. But again, the thrashing this morning in his kennel potentially could have been longer. So the question you're going to be having in the back of your head was this an epileptic seizure? Now, the first events could potentially be something like idiopathic head tremors, although a patient should not be bothered if they do have idiopathic head tremors by the episode that's occurring, the way he was scratching at his face. So after you've obtained the history and you're trying to decipher, was this an epileptic seizure, which given the thrashing that happened this morning, you're going to be more concerned that those were focal seizures and now he's had a generalized epileptic seizure. What would you like to do next in this patient after getting the history? So ideally, you should be thinking of doing a physical examination and a neurologic examination. What ideally should you be doing next? And I'll leave a brief pause between each of these so that way you can think without having to pause the video each time, and then I'll give you the answer after about a few seconds. So ideally, the next thing to do would be a minimum database. Again, getting a CBC, Chem, and a urinalysis. The reason why we're going through this is the thing that should be at the top of your list right now is this could be an epileptic seizure. And when we're talking about classifying something with idiopathic epilepsy, we need to think of that tier 1 level of confidence in order to call a patient an idiopathic epileptic. So doing things like bile acids in this case are not necessarily needed unless we did our minimum database and saw something that was quite remarkable to us. And then doing something like an MRI is also not necessarily needed at this point. It is not wrong to perform these, but it is not absolutely needed right now. So as far as our physical and neurologic examination, we did have mild delayed proprioceptive placement in the pelvic limbs. So if you can see here, the thoracic limbs are very brisk and the patient corrects them very quickly. But when you look at the pelvic limbs, just a little bit delayed, but he does correct them each time. And it's the same on both sides. It's very symmetrical. As far as our minimum database, we do see that our ALT is mildly increased at 112. And at this point, with the ALT being mildly increased, there could be concern that there could be liver involvement. However, it's not uncommon for a patient to have mildly increased ALT following an epileptic seizure. There's a couple reasons why this could be. You can get hypoxic injury to the liver itself from a seizure that's occurring, and there's also a form of ALT within the muscle. And so if you have a severe enough seizure with thrashing, the movement itself could cause an elevation in ALT, or potentially if there's damage and bruising to the muscle from the thrashing, that can also cause an increased ALT as well. So although this could indicate that there could be some mild liver abnormalities, remember that ALT is not specific for the liver itself. So what would your next step be in this patient, assuming epileptic seizure at this point? So the options would be to monitor the patient for 24 hours in hospital. Another option would be to have the owner monitor the patient. And then the last recommendation would be to begin an anti-epileptic therapy. So if the owner does not want to start an anti-epileptic drug, they should be monitored for 24 hours in hospital, because you should be most suspicious of an epileptic seizure at this point, and seizures cause seizures. So the more seizures you have, the more likely you are to have another seizure. So we like to monitor them for 24 hours. One, then you can actually view the event. And then two, if an event occurs, you can act quickly to help stop the event that's occurring. If this was not a seizure, as far as things like narcolepsy, syncope, vestibular disease, paroxysmal dyskinesias, motor unit diseases, all of those would be very unlikely to cause the events that we're seeing, especially when you put into that most recent episode that the thrashing had occurred. Other things that should make you suspicious that this was an epileptic seizure is that the ALT is mildly increased and that there's mildly delayed proprioceptive deficits. Also, the patient seemed abnormal for about 20 minutes following the event this morning. So all those things should be making you think that this was truly an epileptic seizure. And we do know that Labradors are one of the known breeds for idiopathic epilepsy and not a breed known for one of the movement disorders. So again, this was most likely an epileptic seizure. And the videos that we saw before were most likely a form of a focal epileptic seizure. So given that this patient could have potentially had 3 seizures at this point, 2 being a focal epileptic seizure and 1 being a generalized epileptic seizure, the recommendation should be to start an anti-epileptic medication. Now, anytime you start an anti-epileptic medication, it's good to go over the side effects with the owners, but it's also important to remember that the drug itself has side effects and everything else that comes with it, such as giving the medication, the hassle of giving the medication, remembering to give it, the cost of giving the medication, the long-term effects that can happen when giving the drug. So sometimes the issue of giving the drug itself is more than the seizure itself. But that scale can easily tip depending on how bad the seizures are, how frequent the seizures are, and it will depend on the patient and the owner itself. Because some patients after a seizure, during that postictal phase, if they have days of being abnormal to where their behavior's off, if they're blind, that can really affect the owner and the patient as well. And so in those cases, those people are going to be very prone to giving anti-epileptic drugs. Versus if the seizures are very mild, they're only happening very infrequently. So every other month, every 6 months. It's not uncommon that we see patients for a completely unrelated cause. So say we have an 8-year-old dachshund who's down in the back legs. Sometimes when we get a history, the owners will say, oh yeah, he's had seizures for the last 4 years, but he only has one about every 6 months, so he's not on any medications. So in those cases, it's completely reasonable to not start an anti-epileptic drug. But in this case, because this is a breed known to have difficult to control idiopathic epilepsy, and we're suspicious that 3 have occurred at this point, with the last 2 being within 24 hours of each other, starting an anti-epileptic medication is going to be the recommendation. So the question is, which anti-epileptic do you give? Now, in this point, we do see that the ALT is mildly increased and that our proprioceptive placement, our conscious proprioception, is also mildly delayed. So is it possible that this patient could have either structural or metabolic abnormality? It is absolutely possible. However, as we previously discussed, it's not uncommon for ALT to increase following a seizure. And as far as the conscious proprioception being delayed, you can have post-ictal neurologic deficits for up to 48 hours following a generalized epileptic seizure. And in some, although not very common instances, some of those neurologic deficits can be present for even longer. So ideally, in this situation, you would want to recheck blood work and a neurologic examination. In this patient, at recheck, the ALT was normal and our neurologic examination was normal. And so that makes us even more suspicious that this was an epileptic seizure. And so at this point, given the patient's signalment, given our neurologic examination and our minimum database, we can be confident in calling this a Tier 1 idiopathic epileptic. If the ALT continued to be abnormal, if our neurologic examination continued to be abnormal, then the recommendation should be doing bile acids and an MRI at that point. As far as which medication we would recommend starting, it's going to be phenobarbital in this patient. A young, dog that's suspected to have idiopathic epilepsy, your best chance of controlling the epileptic seizures is going to be with phenobarbital. And just as a note, and we'll talk about this a little bit more later on, it's always a good idea to start with just one drug rather than starting with multiple drugs, because the side effects can start to be synergistic with each other. Now, if in this patient we were concerned about waiting 2 days to recheck blood work and a neurologic exam, it is completely reasonable to start phenobarbital. Just make sure that those owners come back within a couple days rather than the 2 weeks to have that rechecked, to make sure that nothing is continuing to get worse that makes you concerned that this is not idiopathic epilepsy. Not every owner is going to be able to do that, but that should be your recommendation. So with phenobarbital, again, the dosage you don't have to remember right now, but just so you have the reference, the starting dose is usually around 2.5 to 3 mg per kg every 12 hours. It comes in tablets of different sizes, so it's good to have a little bit of a range so you know what tablet size to give. Ideally, after starting the phenobarbital, you should recheck everything in 2 weeks, so repeating your biochemistry panel, your CBC, and then also your phenobarbital level. And then you should recheck in 3 months because that's when the hepatic induction occurs. And then every 6 months thereafter, and any time there's a change in the dose of phenobarbital, this timeline should restart. So for this case, it was quite convenient, and we were able to start with 1 grain tablet, so 64.8 milligrams, and we were giving that every 12 hours. So after starting this dose, the next thing you should ask is, what do you do next? And the answer should be recheck the phenobarbital level in 2 weeks, because that is when steady state should have been reached. And then also rechecking your CBC and your biochemistry panel. So in this instance, our drug level is 17, and we have a normal CBC and chem. So now, what are some questions that you would like to ask the owner? So there's a number of questions that you could ask as far as how's the patient doing, but the most important question in this circumstance is going to be, have there been any more seizures? And this owner said yes, there's actually been 2 seizures that have occurred similar to before. One happened at night, the other happened in the morning. So at this point, what are going to be your recommendations? So ideally, you should increase the phenobarbital. We are nowhere close to being at the maximum dose. Again, our drug level was 17, and we can go up to 35 pretty safely. So in that circumstance, do a quick calculation as far as what dose would you increase this patient to still be within the therapeutic range and not give too much. So any answer between 97.2 milligrams and 129.6 is completely reasonable. The 97.2 would be 1.5 tablets, and that should get you to around 25 micrograms per mil. And then the 129.6 is double the dose, so that should get you to around 34 micrograms per mil. Part of the reason as to why you might choose one dose over the other is going to be what are some of the side effects, and then how does the owner feel about the seizures. Because for some owners, they'll say, if my dog has another seizure like this, I'm going to euthanize him. And in those instances, you might as well just pull out all the stops and put them on the highest dose within the therapeutic range. If the owners are not too concerned about the seizures and they're more concerned about the side effects from the phenobarbital, from the ataxia, the PUPD or polyphagia, you might consider not going quite as high on the dose quite yet. The next thing you want to do after increasing the dose is recheck the phenobarbital. For this patient, they were concerned as far as some of the side effects of the phenobarbital, so we only went up to the 97.2 milligrams. And when we rechecked the phenobarbital in 2 weeks, it was actually only at 20 micrograms per mil. So looking back, one of the things that we should have been asking the owner is, when was the phenobarbital being given? Because it can have the peak serum concentration anywhere between 4 to 8 hours after giving the phenobarbital, usually closer to the 4-hour range. So if, say before, when the drug level was 17, if that was right at 4 hours, that could have been a peak. Whereas now, if this 20 is around 8 or 10 hours after the phenobarbital was given, that might explain why it's lower than what our calculated dose was expected to be. The biochemistry at this point has revealed a mildly elevated alk phos at 115 units per liter, and then our CBC is still normal. So at this point, what are some questions that you might have for the owner? So the big question should be, were there any more seizures that have occurred? And the owner states no additional seizures that they're aware of. So now, what would be some of your recommendations? So in this case, we are at the point finally to where we can go to the 3-month recheck. And here at 3 months, we should recheck our phenobarbital levels. And we get them back, it's at 14 micrograms per mil. Our alk phos is still mildly elevated, but not too much different. And our CBC is still normal. So now at this point, what are some questions that you have for the owner? Again, were there any more seizures? And for this patient, the seizure did occur about 2 days ago. No seizures prior to that. So now, what are some possible recommendations for this patient? So one option would be to increase the phenobarbital. We're back down to 14 micrograms per mil, and the dose range is 15 to 35. Now, there's going to be outliers, so that range is based on a certain percentage of dogs responding to the phenobarbital. So that means some dogs can be lower than the recommended dose and still have good efficacy on the phenobarbital. Given that this patient previously was at 17 micrograms per mil and did not have good control, it makes me concerned that the 14 micrograms per mil is not going to be enough. So increasing the phenobarbital at this point is completely reasonable. However, it has been almost 3 months since the patient had another seizure. And so for some people, again, this comes down to the drug versus the seizure as far as the side effects from the drugs, the cost of the drug, the issue of giving it, because as you can tell at this point, the costs can definitely start to be adding up with all these visits that we've been doing with this poor patient. However, there's other times where the seizures are so severe, so frequent, that we might want to increase the medication. So at this point, there's not going to be a 100% right or wrong answer. I would have recommended increasing the phenobarbital to get our phenobarbital level close to the 28. Because if you remember, it was at 14 micrograms per mil, and he was on 97.2 milligrams. So we ended up getting our phenobarbital level exactly where we calculated by doubling the dose to 28 micrograms per mil. Again, it's important to ask the question, when was the phenobarbital last given? Worrying about the peak versus the trough of the phenobarbital level. Now, the other thing that you should recheck at this point is going to be a biochemistry panel. Now, again, cost is starting to be a concern for this owner. So we were only able to do just the liver profile to help save on cost. The ALP is still elevated. It's a little bit elevated from the last biochemistry profile that we have, but it's still not significantly elevated to where we'd be concerned about any sort of severe liver issue. We were not able to do a CBC either, so we just did a PCV and it was normal. So now at this point, as far as the question to the owner, you're going to be asking again, were there any seizures in the last 2 weeks? And they said no. Other questions to ask is, how are they tolerating the phenobarbital? How are the side effects? How's the owner doing with everything too? It's important to take them into consideration. Although we are here for the patients and we need to be advocates for the patient, the owner ends up making the ultimate decision. So now at this point, what would be your recommendations? Ideally, it should have been recheck in 3 months. And as far as things that we would recheck, it's going to be the phenobarbital level, along with our biochemistry panel, and ideally a CBC. So here we do a phenobarbital level, and it's 25 micrograms per mil. It was 28 before, so not a huge difference, and it can wax and wane a little bit, so that's not overly concerning. Our ALP is a little bit down from last time, which it can also wax and wane, so that's not overly surprising. So now at this point, you want to ask the owner, how have things been going at home? And they tell you that the patient has had a seizure 2 days ago. So now what are your recommendations? So you have this patient who's within the therapeutic level of phenobarbital, although we still know we have room to go up. And we're about 3 months in between seizures. And so whenever we have a patient with idiopathic epilepsy, the goal is to try to get them to have 1 seizure every other month or longer. So this patient falls into a category that most owners and most veterinarians are going to be happy with, to where it's been about 3 months in between seizures. So at this point, it's completely reasonable to still monitor this patient and just have the owner give you a call if another seizure occurs, because then you can make changes to the medication at that point. So now the next thing you want to do is recheck at the 6-month time point. So this is 6 months from the change of the medication, so 3 months after the last phenobarbital level. And here we see our level is 28 micrograms per mil, so it's where it was at initially when we changed the dose, so this is to be expected. And again, you can ask when the medications were given, because based on the hour, the peak and trough of where phenobarbital is going to be, it's not uncommon to get mild fluctuations like this. We see our liver profile that ALK phos has gone up more. It's at 344. But this is still not a level that I would feel concerned about, especially because we know liver induction has occurred. So now at this point, what are some questions that you would want to ask the owner? And ideally, you're going to be asking, have there been any seizures? Again, how is the owner doing with giving the medications? How do they feel about the side effects? And again, you can ask, when was the phenobarbital given? And now, what are your recommendations going to be for this patient? So ideally, you check them 6 months after that. So now we're at the 1 year time point. So this patient, the previous examination, had not had any seizures, so had gone over 3 months without any epileptic seizures. So here at our recheck, we're going to repeat our phenobarbital level. And we see that it's down a little bit at 22 micrograms per mil. And when we look at our biochemistry profile, we see that our ALK phos is elevated more so than last time. But these are not uncommon as you have enzyme induction. And we were able to do a full biochemistry panel this time. There had been enough time in between things that owners were able to save up some money. And we were also able to do a CBC as well. And we found that there were no significant abnormalities. So now at this point, you're going to be asking the owner again, were there any seizures that occurred? And then especially at this point, you should be saying, when was the phenobarbital given? Because if it's exactly the same time point as last time, you might be concerned that we're starting to get more induction of the phenobarbital, which is not uncommon this far out on the medication. So as far as what we should do with the phenobarbital at this point and recommendations, we have gone close to 9 months without a seizure. So could this be a patient that has now outgrown its idiopathic epilepsy and is no longer going to have seizures. That is possible, but extremely unlikely. What's more likely is the phenobarbital is doing a good job. It's also possible the dog could have had some more mild or focal seizures that the owners just did not recognize. They're not going to be able to monitor this patient 24/7, so that's something else to keep in mind. So as long as they are tolerating the medication well, which looking at this patient's blood work, and if the owners are not mentioning any significant side effects, I would say that this patient should stay on phenobarbital. The only times to consider stopping phenobarbital is if they're having severe liver issues or idiosyncratic reaction, or if they've gone at least 1 year without a known seizure. Now, in those patients that have been investigated as far as stopping the phenobarbital after 1 year, when they stopped the phenobarbital, 90% of patients ended up having seizures again. And the majority of those patients were no longer seizure-free after they started having seizures again. So, although, yes, the phenobarbital is not a benign medication, it is still likely doing something in your idiopathic epileptic patients, even if they're seizure-free for a year or more. So your recommendation is going to be to stay on the phenobarbital. And so you recheck 6 months after that. And we do our phenobarbital level. We see that it's 28 again. So it's where we were hoping it would be based on our initial calculation. We do our liver profile. We see that our alk phos has not really changed that much. And so at this point, you're going to be asking the owner, have any more seizures occurred? And the reason why they made this appointment is because the dog actually had a seizure last week. The only thing that they had really noted, just because you had mentioned it on the first examination, was that they had given HeartGuard 2 days prior. So a question they're going to be asking is, could the HeartGuard have caused the seizure? Now, if this patient had been on HeartGuard this entire time and had never had a seizure associated with it prior, then I would say no, it's probably not the HeartGuard. It's probably related just to the patient having idiopathic epilepsy. And with idiopathic epileptics, we know that they can wax and wane, and they can go through periods where they can go months without having seizures, and then for whatever reason, the seizures can come back. And it's not uncommon that when they come back, they can be more difficult to control. And so that's something that I would be concerned about, that this is still an idiopathic epileptic who is starting to have seizures again. So at this point, with your recommendations, should we increase the phenobarbital? Or should we just monitor this patient? We know our level is 28, and the dog went almost 18 months without an epileptic seizure. And that we had talked about before. So probably not the HeartGuard. So at this point, my recommendation would be to just monitor. We've gone 18 months. We're not at max level of the phenobarbital, but we're starting to get close. Initially, this patient did have some side effects with sedation and PUPD on the phenobarbital that really concern the owners. So I would leave well enough alone at this point and just monitor them. Unfortunately, the owner called 1 week later and stated that the patient had another seizure. So now, what are your recommendations going to be? So ideally, I would still increase the phenobarbital. I know we're starting to get close to the 35, but we're not quite there yet. So if you do your calculations and decide we want to get close to 35 micrograms per mil, that's going to put us at 243 milligrams. But that's a little bit of a weird tablet size. So most likely what you'll do is get them close to 32 micrograms per mil. So we're going to increase to 3.5 tablets on our phenobarbital based on what our previous milligrams were the last time that we got the drug level. So now everything restarts. You're going to recheck the phenobarbital level in 3 weeks. When we recheck it, we increased it to the 3.5 tablets, and we see that it's 33 micrograms per mil. Our outphos has not really changed that much. So again, cost is starting to be a concern again for these owners. So we were only able to do a liver profile, which is very reasonable with phenobarbital. So now what are going to be some questions and recommendations for this owner at this point? And ideally, you'd be asking, did another seizure occur? And the answer was no. Again, how's the patient tolerating the medication? How is the owner doing with everything? And then you're going to have them come back in 3 months, again, to recheck our phenobarbital level, recheck our liver profile, and again, see how the patient has been doing. Now, I have a little bit of a typo here, but the patient has not had any seizures in the last 3 months. I apologize for putting 2 weeks. However, today, the patient does seem more clingy than normal. And so this has not been reported before with this patient. However, the seizures can change, they can evolve, and you can start to have pre-ictal changes as well, so a prodromal type phase. Regardless, we're not quite certain what's going on with the patient being more clingy. Again, this is a new type of behavior. So what would be your next recommendation for this patient? So ideally in this case, I would just monitor them and see what evolves, see what happens. Unfortunately, the owner calls in one day and says that the patient had another seizure. So what are going to be some recommendations? Do we increase the phenobarbital and get that extra quarter tablet? Go from 33 to 35 milligrams or micrograms per milliliter. Do we start a second antiepileptic medication? Or could we potentially do something that's called pulse therapy with some of the antiepileptic medication? The one that it's done most commonly with is going to be Keppra. So the way that pulse therapy works is you give a loading dose of that medication. So for Keppra, it's going to be 60 mg per kg. And then 8 hours after that, you go down to, in this case, 40 mg per kg every 8 hours for 3 days, and then stop. So if you have patients with prodromal signs, it could be an opportunity for them to get loaded with Keppra to try to prevent a seizure from occurring. If the patient, if not on phenobarbital, then you would only give 20 mg per kg of Keppra for that patient every 8 hours. So this is a very reasonable option to do for this patient. I think increasing the phenobarbital at this point is not going to do much for the patient. We're already very close to the high end of phenobarbital. So I think doing something like pulse therapy because of that prodromal period is going to be ideal. However, what if the prodromal phase was not present? You could still do pulse therapy Keppra. This patient went several months without seizures. So if we can just get them through this episode of the seizure, then potentially it will prevent more seizures from occurring. Because again, seizures cause seizures. So if a patient has one seizure, but then you give a pulse therapy of medication for a few days, it can prevent other seizures from occurring, and then hopefully you can get back to baseline of where the epilepsy is at. You could consider just starting a second antiepileptic medication from there on out. Other things that some people might try are diets. So there is what's called the NeuroCare diet, which is supposed to help as far as controlling seizures. It has been investigated and does show promise to some degree, but it's not going to be something that's going to cure a patient that's having idiopathic epilepsy. The idea for the NeuroCare diet came from looking at children with idiopathic epilepsy. And what they found was that if they put these children in a ketotic state, they have decreased seizures in these children. And it's actually sad how the idea of this came about, because we don't really understand why a ketogenic diet would cause this. But back in the times of the Great Depression, when there were more and more children that were having epilepsy, they noticed that the children, when they would start to starve and go into a ketotic state, would stop having seizures. Now, in dogs, it's very hard to put them on a diet that's going to push them into a ketotic state. So this diet does not put them into a ketotic state. It just changes the way that the brain is using some of the short chain and long chain fatty acids. So in a sense, it's putting the brain in a ketotic state, but the body's not going to be in a ketotic state. And that is a gross oversimplification of this, but I don't want to get into too much detail of it. Another thing that's gained a lot of traction is CBD oil. There's a couple studies that have investigated it. The CBD oil is not benign, and it can actually change the metabolism of certain medications. So if you have a patient on zonisamide and you put them on CBD oil, it actually inhibits the metabolism of zonisamide, and you can start to get high levels of zonisamide in those patients. So CBD oil is not something that I use commonly. I have a lot of owners that ask me about it, and I think it does have its place, but until we get more information on it, it's not something that I'm going to recommend in a lot of my cases. Now, for some patients, when they're on 4 different anti-epileptic medications and they're on the NeuroCare diet and we're to a point to where we're going to euthanize the patient, it's absolutely something I'd be willing to try. But again, it's usually not something that I'm going to jump to. Same thing with the NeuroCare diet. I think it's very reasonable to try it. It is quite expensive, especially in larger breed dogs. It's not wrong to do it, but if they're on the NeuroCare diet, they can only be fed the NeuroCare diet. They can't be given any other treats. They can't be given any table food. They have to be given the NeuroCare diet, and that only for it to have any sort of effect. So if we were going to start a second anti-epileptic drug and did not want to do the pulse therapy, as far as some options, we could start with potassium bromide. It's most likely the one that's going to be helpful in controlling the epileptic seizures, but it has such a long half-life that for some of these patients, it might not be a good option. However, for this Labrador, it's an option that might be very reasonable. For Keppra, it seems to be a fast-acting anti-epileptic, but some of the studies would say it's not going to be as effective as potassium bromide. And then same thing with zonisamide. There is not enough evidence as far as saying that it's going to be a good choice, and some of those dogs have severe idiosyncratic reactions, although they're quite rare for them to occur. If they do happen, it can be catastrophic. Zonisamide is definitely a drug that I've used in a number of different patients. I've never personally had any issues with it, but I have seen a couple patients that have had that liver issue to where they develop hepatic necrosis, and in one of the cases they did succumb to the condition. But that being said, if we're to a point to where an owner is considering euthanasia, then what do you have to lose starting zonisamide? Even if that side effect occurs, it's extremely rare for it to occur. Another thing you could do is just consider doing pulse therapy Keppra until the KBR gets to therapeutic levels. And again, this goes back to weighing the side effects of the drug versus the seizure. So that's going to be it for the first case. I don't want to dwell too much on this patient. This patient is still doing well. We ended up doing the pulse therapy of Keppra and started potassium bromide at the 20 mg per kg every 24 hours. And the patient was a little bit sedated and ataxic at first, but after about 3 weeks or so, the patient adapted to the potassium bromide. We sent home Keppra orally for them to give as a pulse therapy if a prodromal phase occurred, but another one never occurred, and we ended up eventually never using it. And as far as I know, the patient has not had any more seizures being on the combination of phenobarbital and potassium bromide. The next case that we have is a 4-year-old male castrated pug whose name is Porky. And this was a patient who presented with facial twitching and lethargy. The history is that starting a week ago, the facial twitching had been noticed, and it's been getting worse and worse and more frequent. Overall physical examination is unremarkable. However, as you'll see shortly, neurologic exam was by no means normal. And if you look on the left side of his face, as the videographer is pointing out, you can see the facial twitching. Other things that you should notice is this dog's behavior and mentation are very much abnormal. And I would consider this patient obtunded. For our neurologic examination, obviously we saw the seizures. And some other things that we noticed was an absent menace in the left eye. There were visual deficits in the left eye with a normal PLR. There were left conscious proprioceptive deficits as well. However, this patient did have a normal gait. The patient also had hemiinattention and decreased response of nasal stimulation on the left side. So at this point, the next thing I want to ask you is, can you localize this patient? And if so, where do you localize to? If you need to go back and look through, as far as the localization, some of the abnormalities, that's perfectly reasonable to do, but you should localize this patient to the right forebrain. You should immediately be thinking forebrain because there's seizures present. Even though they're focal epileptic seizures, any epileptic seizure is going to be forebrain in nature. And then as far as it being right forebrain, that makes complete sense because there was facial twitching on the left side. And remember, decussation occurs at the level of the forebrain. So if you have a area that's going to be a generator for epileptic seizures on the right side, then you should see the motor response on the left side of the body. And then everything else, as far as the deficits, the visual deficits, the proprioceptive deficits, the hemiinattention, that was all left-sided as well. So this is a classic right-sided forebrain lesion. The next thing you should be thinking about is, do you think this patient has idiopathic epilepsy? Or could it be something structural, unknown, or potentially reactive epileptic seizures? Based on that, you should come up with a diagnostic plan. So it can be a little bit tricky because we said that epileptic seizures can cause neurologic deficits. However, when they're this lateralized and this severe, it should make you more concerned about something structural. So the ideal recommendation after doing your examination, it is completely reasonable to recommend doing a CBC and a biochemistry panel. But ultimately, you should be thinking that this is a structural lesion and MRI is going to be the recommendation. So this is the patient's MRI. And these are transverse images. On the left is going to be a T1. On the far right is going to be a T1 plus contrast. And in the middle is a T2 weighted sequence. So if you look at the T1, there's nothing that is overly remarkable other than you can see that there's a midline shift. Now, whenever we look at any sort of radiographic imaging, the right is going to be on our left and the left is going to be on our right. So we can see that there's a midline shift to the left in this patient on the T1. On the T2 weighted sequence, we can still see that there's this midline shift, but we can see this intraaxial hyperintensity within the right cerebral hemisphere. And when we look at the T1 plus contrast, we can see that there is some neighboring contrast enhancement to where that T2 weighted hyperintensity was. Looking at this MRI, the next thing you want to ask yourself is, what is the most likely diagnosis for this patient? And given that this is a 4-year-old pug, the thing that should come to the top of the list is going to be meningoencephalitis of unknown etiology. Other possible differentials could include an infectious encephalitis or potentially neoplasia, with the two most likely neoplasias given those MRI findings is going to be glioma or potentially lymphoma. So in this case, where we're most suspicious of MUE but can't be 100%, the next thing that we typically do is going to be a spinal fluid analysis. So meningoencephalitis of unknown etiology is broken up into different subcategories. There's GME, which is granulomatous meningoencephalitis. There's necrotizing leukoencephalitis, and then necrotizing meningoencephalitis, which is known as pug dog encephalitis, and unfortunately is most likely what is occurring in this patient. So as the name implies, there's necrotic lesions that occur with NME, versus with GME, there's only going to be granulomatous lesions and not areas of necrosis. As far as the cause, it's thought to be an immune-mediated condition. However, some speculate that, at least in some of the cases, there could be an unknown etiologic agent present. And MUE is something that can affect any and all parts of the brain, although at times it can be focal. As far as the diagnosis, most of these patients are going to have an abnormal neurologic exam. It's very uncommon that a patient is going to present with just seizures, or if they do present with just seizures, you should be able to find something else on your neurologic examination that's going to make you concerned that this patient has some sort of space-occupying lesion or structural epilepsy. Again, it can be focal or multifocal in its localization, just because the MUEs can affect any or all parts of the brain. And typically, when we do our CSF, there's a mixed cell inflammation, although typically it's going to be mononuclear pleocytosis, so a mix of macrophages and lymphocytes. Now, the changes that we see on our spinal fluid analysis and with MRI can be very similar to infection. So ideally, you should run either serology or PCR for certain infectious etiologies that could mimic the changes you're seeing on MRI and spinal fluid analysis. Ideally, to diagnosis, a biopsy is going to be needed, but most of the time we don't end up doing a biopsy. As you can imagine, the method of doing a biopsy of the brain is not going to be benign. It's not without potential consequences, and it's also not without its cost. As far as the treatment, all these patients are going to be put on prednisolone or prednisone, along with another immunomodulatory agent is listed there. I'm not going to go into the details. But it's also important that these patients need to be on an anti-epileptic as well, with the most effective one being phenobarbital for patients with MUE, although some people will try to start out with a medication that's not going to add to their already existing neurologic deficits. Unfortunately, prognosis looking at MUE as a whole is usually around a year, with GME potentially having a little bit longer survival time and the NMEs having a little bit less of a survival time. But as far as our average survival time, it's usually somewhere around a year with MUE. The next case we'll talk about is Gretchen. She's an 8-year-old female spayed Norwich Terrier. And the history is the patient was bit on the head by a housemate, and after being bit on the head, the patient did have a seizure in the car on the way over. As far as on the exam, you can see a visible head wound, and the owner's description is consistent with a generalized epileptic seizure. The patient otherwise appears stable. So in this circumstance, say if you're working at a general practitioner's office, what would be the ideal plan for this patient? So ultimately getting to referral would be the ideal plan, but as far as things that you could do in your office, one potential thing would be to radiograph the head. And if you see that there is a wound with communication into the calvarium, referral needs to be recommended. Unfortunately, in this patient, they cleaned the wound, clipped and cleaned the wound, and then started Clavamox. 4 days later, the patient began circling to the right, and then later it developed 3 seizures that night. And the owners noted that it was not acting right. So at this point, as far as the cause of the epileptic seizures, you're going to be most concerned that this is something structural. And the structural lesion being something like an abscess from the trauma, although something like a hematoma could potentially be possible, and a depressed fracture as well. So here, ultimately an MRI was performed, and we see that there's this large space-occupying lesion within the left cerebral hemisphere. Again, the left is on our right, and our right is on our left whenever we're looking at these patients. So the patient is looking at us in these fields. And what you should notice is on the top left, think about what kind of imaging sequences actually all these images are. Are they going to be T2 or T1 weighted? So these are all T1 weighted sequences, and you can tell this by looking at the ventricles, and you can see how they're hypointense. So fluid is going to be hypointense on MRI for T1. And the reason why there's a hyperintensity surrounding these hypointense space-occupying lesions is because this is following contrast. So what are some clinical signs that you would suspect when a patient has signs like this? So things that you would expect are going to be epileptic seizures, visual deficits on the right side. So again, this is the left cerebral hemisphere that we're seeing this. They'll have a head turn towards the lesion and will circle towards the lesion as well. So those are some potential signs that you could see with this patient. And here's what this patient looks like after we got the wound clipped and the patient intubated. Now, ideally in this patient, referrals would have been recommended. We could have done the MRI initially and then done surgery. And part of what was seen on the MRI is actually a depressed skull fracture, which is being pulled out from this patient right now. So with traumatic brain injury, seizures may develop acutely or it can be delayed. And in about 6.6% of dogs with traumatic brain injury, they can have post-traumatic epilepsy. As far as when there's indication that a head trauma could involve neural tissue, if you have a patient that is presenting with seizures following being bit on the head, that should be a red flag that there is neural tissue involvement. Now, could it be something like a concussion or a contusion? That's absolutely possible. But if we're talking just from a bite and then a patient having this seizures immediately following that, there is likely involvement of the neural tissue immediately. So that's why the recommendation in this patient was to start with a radiograph. Other things that can happen, you can get a hematoma or hemorrhage that develops, the depressed fracture as well, like in this patient, and that can serve as a nidus for infection. And then eventually an abscess can develop as well, which this patient also had, which is why there was so much contrast enhancement on the MRI. Remember that in these patients, you need to treat the seizures as well as the underlying cause. So in this patient, we were able to do surgery, luckily, and remove the skull fracture. We can put him on antibiotics, especially after we culture the skull fracture, and put him on anti-inflammatories if indicated. The next case we will discuss is a 9-year-old male castrated boxer named Gus, who's presenting for seizures. The history is that the patient has had 2 generalized epileptic seizures witnessed by the owner. The client's previous dog was a littermate of Gus, and he developed seizures from a glioblastoma and had passed away from that. This is the patient's examination. So watching as far as his ambulation, you should be looking at his gait. What does his posture look like? What do you think of his overall mentation and behavior as well? So there's no obvious evidence of ataxia in this patient, no evidence of paresis or weakness that can be seen. Unfortunately, I can't get the cranial nerve examination video to work, but his cranial nerves were normal. And as you can see here, his conscious proprioception is normal. Might have been a little bit delayed in that right thoracic limb, but that's not uncommon for a patient with a catheter present. Again, good proprioceptive placement. You can see he was looking at his catheter and accidentally pulled out his cap. So this patient's neurologic examination was very normal. So as far as our neurolocalization with a normal neurologic exam, we would still think that the neurolocalization would be forebrain. We just can't say which side. The reason why we say it's forebrain is because the patient is having seizures. As far as what is the underlying cause of the epileptic seizures, could it be idiopathic, structural, unknown, or metabolic? Given this patient's signalment, idiopathic is not one that we would say is possible. They're not the right age and they're not the right breed. Something structural or unknown is going to be most likely, and I did forget to mention it, but we did do a CBC and biochemistry panel, and those were normal, so metabolic is very unlikely in this patient. As far as our differentials, neoplasia would be at the top of the list despite having a normal neurologic examination. Something infectious or inflammatory is possible, so something like MUE can still occur in older dogs, especially GME. Another possibility would be a cerebral vascular accident or stroke. So again, because structural is the most likely cause, as far as our plan and what our recommendation is going to be, MRI should be the recommendation. And here we have 3 different MRI sequences. So these are transverse sequences. On the very top is going to be a T1 pre-contrast. In the middle is going to be a T1 post-contrast. And then at the very bottom is going to be a T2 weighted image. At the very top, we can see that there's a hypointense region, and that kind of correlates to the hyperintense region seen on the T2 at the very bottom. And then we can see this ring enhancement pattern in the middle image. And this kind of imaging pattern with a hypointense area on T1 that's associated with a hyperintense area on T2 with this intraaxial space-occupying mass with ring enhancement is very consistent with a glioma, although we still can't rule out other causes of neoplasia or potentially some sort of a granuloma as well, whether it's infectious or non-infectious. But being a boxer, glioma is by far and away the most likely differential in this patient. And remember that neoplasias, depending on their location, how slow growing they are, they can be occult and not have any other neurologic deficits and only have seizures as their presenting complaint. Now, with intracranial neoplasia, about 25% of dogs will have tumors outside of the body, but a lot of times those tumors are not related. So as far as a plan in this patient, if they can't afford to do an MRI, doing thoracic radiographs to look for neoplasia elsewhere, an abdominal ultrasound, doing blood work, all that is completely reasonable to do. Another differential that we had discussed was cerebrovascular accident. So if you have a patient to where you can't do an MRI, it's completely reasonable to do a workup to look for underlying causes of cerebrovascular accidents, as about 50% of dogs will have an underlying cause. Some of those causes are hypothyroidism, diabetes mellitus, hyperadrenocorticism, chronic renal disease, or hypertension. However, on that note, seizure is very uncommon as the first sign of stroke, although the more we're doing MRI and the more we're getting biopsy, we're starting to find that it is still possible to have seizure as the only sign in patients with cerebrovascular accident. So we just have a couple more cases to go. So this case is Bubbles, a 4-year-old spayed female bulldog, an English bulldog, whose chief complaint is seizures. And the patient has been having persistent seizure activity for the last 18 weeks. So it's been occurring fairly regularly for a decent period of time. The owner doesn't notice any other issues with the dog, and this is what the episodes look like. If the owner distracts the patient enough with a treat or with a toy, she can sometimes get the episodes to stop, although not always. And the patient has been placed on phenobarbital, but has not had any sort of response. A minimum database has also been performed, and everything has checked out normal. So in this patient, if you compare this to our first patient, the only thing that's really involved, although you can't see the rest of the body, is the head. The limbs aren't involved. The dog is not pawing at his face. He doesn't seem to be really bothered. And there you can see she called the dog, and it stopped for a moment and then started again. So this is a good example of a patient with idiopathic head tremors. And in bulldogs, they tend to go in the yes or up-down direction. The other breed that this has been reported in is the Doberman, who, for whatever reason, tend to do the no or side-to-side direction. So this is likely something that's idiopathic. We're not exactly sure what the cause is. Some people think that it's some sort of paroxysmal dyskinesia or movement disorders. Other people think that there's a defect in the stretch receptors. Some of the more recent evidence do say that this could be a form of focal epileptic seizures, and there has been kind of mixed results with giving levetiracetam or Keppra to these patients. So the debate is still out there as far as what these are. Although it does appear to be benign, these patients don't have changes consistent with what we would see with idiopathic epilepsy or seizures in general following an episode if we do an MRI. So a lot of the hyperintensity that can be seen following seizure is not present in these patients. And again, you can distract these patients a lot of times and get them to stop having the head tremors. And it's not uncommon that after several months, the episodes will just stop and the patient will go about its normal life without ever having an episode, although in some cases that's not always going to occur. So the last thing that we will talk about is a 6-year-old female spayed poodle. So this poodle has had these episodes that you'll see in the video, and the episodes were occurring once, twice a day for the last week. And then the patient, while at the vet clinic, which is where this video was taken, went into status epilepticus. So here we can see a little bit of licking, and the patient is lifting the left thoracic limb. As far as things that could mimic this, something like seizures, vestibular disease, syncope, some sort of movement disorder, of those that could mimic epileptic seizures, the one would be some sort of a movement disorder, or paroxysmal dyskinesia. However, once the patient went into status epilepticus, immediately you should know that these were focal epileptic seizures that progressed to generalized epileptic seizures and eventually status epilepticus. So where this had occurred, the veterinarian did not feel comfortable treating this patient, so it was referred to us, and it presented with a 2-hour history of status epilepticus. So they were 2 hours away, and then the patient was sent to us. Talking to the owners, there was no known toxin exposure, and there's been no history of epileptic seizures or really any sort of illness prior to this status epilepticus event occurring. So recall that status epilepticus is the failure of seizures to terminate. And as far as what we classify them, if you look at the definition, it's going to be a seizure lasting longer than 20 to 30 minutes. But clinically, we say it's going to be a seizure lasting longer than 5 minutes, because most of the time, if a seizure occurs at home and it lasts longer than 5 minutes, by the time they're going to get to your clinic, it's going to be 20 or 30 minutes that seizure has been occurring, potentially even longer, such as in this patient. And another classification for status epilepticus is going to be greater than 2 seizures without a return to normal consciousness between the seizures. And this is all stuff that we've talked about before in the previous lectures. Status epilepticus is a true emergency, and there's a number of reasons why it is a true emergency. The first reason it's an emergency is because the dog is cooking its brain. There is a lot of glutamate being dumped on the NMDA glutamatergic receptors. While the patient is having seizures, these NMDA receptors are stimulated, and so you're going to get permeability to calcium and sodium, and calcium influx is going to activate second messengers that are going to allow more ions to flow into the cell. So you're going to get swelling that occurs to the cell as water follows those ions, and this is going to lead to what's known as cytotoxic edema as these neurons start to swell. Some of the secondary messengers are going to liberate calcium from inside the cell and in the endoplasmic reticulum. And recall that calcium is a very important intracellular signal. So too much calcium being released is going to activate proteases and lipases, and this is going to damage the cell. There's also mitochondrial damage that can occur either from the proteases or lipases, and also from the mitochondrial permeability pore that's going to be activated from the calcium. And ultimately, the cell, the neuron, can die from either one or a combination of all of these things occurring. And when a neuron dies, it's gone, and it's never coming back. There are stem cells within the brain itself, but these aren't anything that you can really count on. It's not as if though they do a significant amount for the brain after neurons have died. So when an animal is having status epilepticus, you ultimately see brain damage. And this is what an MRI can look like. So we can see this large hyperintense intraaxial lesion on this T2 weighted sequence within the piriform lobe, which is a common place where you can see a region of cytotoxic edema secondary to seizures. And again, this is within the piriform lobe. And those areas, that large area, a large chunk of those neurons are dying because this patient was in status for so long. Now, if that wasn't bad enough, all seizure activity is having a profound effect on the body as well. So not only is the motor system being activated that you can see outwardly, but the autonomic system is seizing as well. So you can have a sympathetic storm and ultimately become hypertensive, you can become tachycardic, you can have arrhythmias, and even become hyperglycemic. And the blood sugar going up can add fuel to the fire as it's going to exacerbate some of the neuronal damage. The net result is that ultimately they can die. And there's a number of things that they can die from when a patient is in status. So probably the most common is going to be from ventricular tachyarrhythmias. And really, if you think about it, these patients are the perfect candidate to develop ventricular tachyarrhythmias because they have these catecholamines that are released. They're hypoxic because they're not breathing normally, or they could have other changes like aspiration pneumonia that's occurred, and they can also be acidotic. And all these things put them at risk for ventricular tachycardia or ventricular fibrillations. They can also die from the respiratory compromise, so the non-cardiogenic pulmonary edema that can develop from that severe catecholamine release that's leading to dilation of the vasculature. That itself can lead to such severe edema that they can die from that. Or ultimately, long term, they can have renal compromise from how severe the myoglobinuria could be, although that is going to be less common. So when you have a patient present in status epilepticus, you need to keep all that in mind. And when you look at your patient, knowing that all these things can happen, as far as what to do for the patient, yes, ultimately stopping the seizure, but some things that you can do while you're trying to get all that together is check a temperature. If they're hyperthermic, they need to have active cooling on them because some of these patients can get to 107, 108 degrees. And that in and of itself can start to cause organ damage as well. Oxygen supplementation is very reasonable because, again, these patients might not have normal breathing patterns, and so their oxygenation can absolutely be low. And then again, ultimately giving these patients anti-epileptic therapy to get them out of status epilepticus. Now, the most common medication that we're going to give initially is a benzodiazepine. And the two that are most readily available in veterinary medicine right now is diazepam and midazolam. Now, diazepam can be given either rectally or intravenously. Now, the bioavailability is quite broad rectally with diazepam. So usually we give somewhere between 1 to 2 milligrams per kilogram. And if you're going to be giving it IV, the standard dose is going to be 0.5 milligrams per kilogram. For midazolam, it can be given intranasally or IV. It can also be given IM or sub-Q. But most of the time, if you're wanting immediate relief of the seizure, giving it subcutaneously or IM is not a good option. The dose for intranasal or IV is going to be 0.25 milligrams per kilogram. Both of these drugs come in 5 milligrams per mil as far as their concentration. So although diazepam can be given intranasally as well, we usually don't give it because the volume makes it difficult for most patients, especially if they're brachycephalic. So normally, if you're going to give one of these medications intranasally, you want to give midazolam because it's going to be less volume. So in this patient, we were able to place an IV catheter. We gave diazepam at 0.5 mg per kg, and the seizure stopped. However, about 5 minutes after we gave the diazepam, another seizure started. So what would you do next in this patient? So ideally you would repeat the dose of diazepam, and the next thing you're going to want to do is start a CRI in this patient. It is not uncommon if a patient has cluster seizures or if they're in status that they're going to be placed on some sort of a CRI. The starting dose for the CRI is 0.5 mg per kg per hour IV, and you can go up to 1 mg per kg per hour if needed, but typically if you're to a point to where that's still not controlling the epileptic seizures, you should consider switching to a different medication. Ideally, you should stay on the benzodiazepam CRI for 6 to 12 hours, and then consider to start weaning the CRI over 6 to 12 hours. And just kind of a general way to think about it, if you started them on 0.5 mg per kg per hour, after 6 hours, depending on how the patient's doing, potentially up to 12 hours, then you consider decreasing to 0.4 mg per kg per hour. You do that for a couple hours, then go to 0.3 mg per kg per hour. Do that for a couple hours, and so on. Diazepam is becoming harder and harder to obtain just because they're not using it much in human medicine anymore. So they've just stopped manufacturing it as much as they used to. So midazolam is becoming more readily available, and it's actually cheaper most of the time than diazepam. So as far as the dose of the CRI and the IV, everything is very similar. It's just going to be half the dose compared to diazepam. Propofol is very reasonable to do. The times where you would consider giving propofol is if there's failure of benzodiazepines after 2 IV doses. So in this patient, if we gave a 0.5 mg per kg dose of diazepam and the patient did not respond, you can repeat it. So now we're up to 1 mg per kg of the benzo. But if the patient has still not responded at that point, then you should consider switching to propofol. But I typically will start with benzodiazepines because 80-85% of the time they're going to work, and they're going to have far fewer side effects, especially if you need to put that patient on a constant rate infusion. Other times where you would consider propofol is if the seizure activity is secondary to hepatic encephalopathy, as there is some thought that the benzodiazepines could make that worse. Same thing with propofol. The seizures, at least in theory, are thought to be worsened if a benzodiazepine is given with certain toxins like ivermectin. As far as the propofol dose, kind of like with intubation, the loading dose is going to be titrated to effect at 4 to 6 milligrams per kilogram IV. Some of these patients will have to be intubated because you have to give that much propofol before the epileptic seizure stops. And then as far as starting a CRI, our starting dose is usually 0.1 milligrams per kilogram per minute. So you will use a lot of propofol in these patients, which is another reason why you try to maximize your benzodiazepines if you can. So once you get the final seizure to stop, the next thing that you should be thinking about is what could be the underlying cause. So think of the patient's signalment. Is there some sort of toxin that they could have been exposed to? In this patient, it ended up being idiopathic epilepsy. We were not able to treat this patient or perform an MRI on this patient, so we treated them with presumed idiopathic epilepsy. The reason why we did that in this case is we couldn't do a neurologic examination beforehand, but based on what the owners described in the history, there was no way that this dog could have got a toxin. If there was the possibility of toxin, then that might have been our number one differential, but this owner had an infant in the house. They said they keep everything on lockdown, and there's no way that this dog would have gotten into anything. And for a patient to go into status epilepticus without any other signs from something like a tumor or something like MUE would be less likely than with idiopathic epilepsy. And about 25% of idiopathic epileptics can present with either clusters or status as their first seizure. And although this patient was starting to get a little bit on the older side, we're still within that age range of 6 months to 6 years, to where idiopathic epilepsy is still considered reasonable. And so we ended up starting this patient on phenobarbital. So after placing him on a CRI and getting the seizures to stop, you should be thinking, what do I want to put this patient on long term? And if idiopathic epilepsy is your number one differential, then phenobarbital should be the number one drug that you are reaching for. So that is going to be the end of this lecture. And just to recap on all 3 lectures, we've gone through the terminology of seizures. We've gone through the causes of seizure disorders and how to diagnose them. Hopefully you have a better understanding of how to treat seizures, both chronically and during the emergency situation, and also know how to monitor and manage a patient on chronic seizure medications, the big one being phenobarbital. With that, that's going to be the end of the seizure lectures, and we will have a Zoom session available to answer questions that you might have.